So I think everyone in the room is very aware that there are several conventional ways to treat cancer: surgery, radiation, chemotherapy, targeted pathway inhibition, including the very important pathway downstream of the androgen receptor. But many of us, for quite some time, have believed that the immune system represents another way to try to treat cancer. And until quite recently, the firm proof of that was a bit elusive. But I think now we have a very firm grasp on the fact that the immune system, similar to its way of controlling infectious diseases, can control cancer. But before we really get into the data, we have to convince ourselves that these two questions are reasonable. Is there an immune response to cancer? Can the immune system see targets on cancer the way that it can also see targets on viruses or bacteria, which is what we believe it was really designed to see? And can the immune system reject cancer? And so we try to imagine, really, that the immune system could possibly see cancer just like it sees a foreign or infectious pathogen, like a bacteria or a virus. But the difficulty, until quite recently, is that we really were stuck trying to understand whether cancer represents self, looking so much like the normal tissue that it came from, or whether it's some sort of altered self. Because if the immune system recognizes cancer as self, it's not going to do a very good job. And so it may need some help to do that. Many of the antigens or potential targets on cancer look very much like self. And so we need to come up with creative ways to coax the immune system into seeing something that it would rather ignore. If we turn back the clock by about 120 years, we recognize that this field has deep roots. So first of all, to acknowledge the ongoing importance of philanthropic support for our field, the young couple on the left is John D. Rockefeller Jr. and his girlfriend at the time. And that young woman would die 1 year later at the age of 16 of a sarcoma that's hiding under the glove of her left hand. And it was the death of that woman, whose name was Betsy Dashiell, that inspired in the Rockefeller family the desire to contribute to medical research and to found many of the great organizations that many of us work with. But importantly as well is the fact that the dashing gentleman who must be involved in prostate cancer research because he's got a mustache there, his name was William Coley, who was the hottest bit of surgical talent in New York City at the turn of the 19th century. The person called on to operate on Betsy Dashiell and who watched her die after he sequentially amputated more and more of her left arm. And Coley had a visionary thought at the time, I think in many ways the first quantum leap. He observed, in fact, that many of his patients who died of wound infections after surgery lived longer, many patients who developed wound infections after surgery lived longer than patients who didn't develop wound infections. And so he came to the startling hypothesis, actually, that wound infections probably stimulate something about the immune system, and that is responsible for patients living longer from cancer. He went on to develop a medicine called Coley's toxins, which was a mixture of dead bacteria that non-specifically stimulated the immune system. But he died with the field still somewhat a mass. And he actually lost out in a bit of a war to radiation therapy that was occurring in the 30s and 40s. And his clinical research, which was largely composed of anecdotes like this gentleman who had a sarcoma in his neck that was injected with this dead bacteria, this clinical research went very much ignored because there was no scientific mechanism yet found to underpin it. But then fast forward over several decades, and we began to observe certain things that made us quite convinced that Coley was right. The first was that in a previously rare skin cancer called melanoma, which is a cancer of the pigment-forming cells in the skin, sometimes areas of regression can be seen, like in that tumor on the left side of the slide, where the center actually has a regressed area of tumor cells. And when the pathologist reads that slide, they will see an infiltrate of immune cells at that site that literally has digested the melanin-producing cells in that tumor. And other anecdotes, like the gentleman, a Hispanic gentleman whose normal skin tone is that area on his chin and under his armpit there, who developed an acral melanoma and who spontaneously depigmented at the same time that he lived for 2 years with kilos of metastatic disease without therapy, convinced us that the immune system can see things on cancer. Sometimes it can't distinguish between cancer and the normal cells that it came from. but that the immune system can see cancer and can respond to it in a way that could control the disease, at least in a limited way. I believe the first true example of the immune system being properly tuned to treat cancer was the development of interleukin-2, largely a result of the work of the National Institutes of Health and Dr. Rosenberg and the group at the surgery branch, developed a pure preparation of a growth and differentiating factor for T cells. This was shown in many clinical trials to lead to durable regressions in patients with melanoma and kidney cancer. And in fact, that medicine was licensed not based upon phase 3 randomized placebo-controlled data, but rather on a long series of pooled clinical trials which showed that about 5% of patients with melanoma treated with that drug, which has no direct activity against the tumor, will live for 10 years or longer. And it is really bona fide evidence that the immune system, when properly controlled, can see cancer and lead to durable regressions. Now, fast forward again until the mid-1990s, when we learn a whole lot more about what molecularly controls the immune system. What are the pathways that activate the immune system? What are the pathways that, in a sense of equilibrium, shut down the immune system? And any of the immunologists in the room will know that the first step, the signal 1, is the recognition of antigen by the T cell receptor. This by itself is insufficient to allow the immune system to get activated. It must happen at the same time that a molecule called CD28 on the T cell joins with a member of the co-stimulatory molecule family, so-called signal 2. When these two things happen, like on the left side of this slide, T cells become activated and a productive immune response is formed. Now, once that happens, another molecule, which is that red fork at the top of the left panel, is a molecule called CTLA-4, and it usually is stored intracellularly. Once the T cell is activated, it moves into this immunologic synapse, where it serves the very simple role of turning off the activated T cell. We know that CTLA-4 plays a critical role in doing so because mice that lack this protein will die of fulminant lymphocytic infiltration of every organ in their body by 3 weeks of age. Some of my colleagues refer to them as walking lymph nodes at that point. But CTLA-4 obviously plays a non-redundant role in keeping our immune systems from attacking self. And with that information in mind, my colleague Jim Allison had the visionary thought to block CTLA-4 for a temporary period of time, because clearly blocking it for long periods of time would not be reasonable. And so he developed a series of antibodies that would block CTLA-4, one of which we now know as Ipilimumab. And I'm going to tell you a little bit about the steps that were taken to take Ipilimumab from an initial observation in mice to the first approved therapy to treat metastatic melanoma based on phase 3 data showing that overall survival could be improved. Now, one of the a priori assumptions we have to make is that when we block CTLA-4 or any other negative checkpoint of the immune system, that this is a non-specific event, that we are liberating all T cells from this inhibitory pathway. And so there must be something about the tumor site or the tumor itself that is going to attract the attention of this now disinhibited immune system. And so if you look at the bottom left-hand corner of that slide, those are all ways in which some specificity can be introduced to this. The first we don't have to do anything about, because necrotic death is something that's seen in many large solid tumors as a result of them outgrowing their blood supply. But the others represent other options of things that we can introduce at the same time or even prior to CTLA-4 blockade to try to enhance some specificity. The first evidence that Jim's theory was correct really came from a simple experiment done in mice that had a syngeneic colon cancer implanted on their backs. And these mice were treated with either an antibody to CTLA-4, an antibody to the activating marker CD28, or nothing. And the result was quite clear. Mice that had an antibody to the activating marker had tumors that grew slightly quicker, but mice that were treated with the antibody to CTLA-4 had tumors that grew for a short period of time and then regressed and remained under control. What we as clinical investigators needed some reminding of is that area in the red circle. Because all of these tumors grew before they regressed, The immune system is not going to directly affect DNA replication or cell division. It needs some time to do the important job of controlling tumor growth, but it's an indirect mechanism. And so we may have to expect that some of our patients are going to get worse before they get better. I think that some of us who are the clinical investigators should have gone back and read Dr. Leach's paper in Science before we started to interpret the clinical data, because I think we would have been a lot smarter in retrospect. But nonetheless, Ipilimumab made it into phase 1 trials. One of the first patients treated with melanoma was at the National Institutes of Health, just up the road a piece, and had a striking regression of 31 lung metastases from melanoma, as well as an incidentally noted brain metastasis. Some patients from these first-in-human trials are actually still alive today, again attesting to the power of the immune system to enact durable regressions of cancer. Now, some patients, like this patient of mine, who was treated in 2006, respond very quickly. That's melanoma on the anterior surface of her left leg, innumerable nodules in the skin and under the skin. And at the time of the 3rd dose of antibody, just 6 weeks into treatment, all of that disease had regressed. You couldn't feel it anymore. But you can see areas of hyperpigmented macules on the skin, making you think that perhaps there's still melanoma there. And so we did a biopsy of that site and found a very satisfying result. Those pigmented areas were not melanoma, but rather they were tumors, if you will, of activated immune cells that had engulfed the dead debris from melanoma cells and were left just with the pigment. And since the pigment that we have in our skin is very insoluble, these will just remain as tattoos. And so this really showed quite visually that the proof of principle for CTLA-4 blockade exists. That where a tumor was before, now we just have an infiltrate of activated T cells, CD4 and CD8 positive T cells, that regressed the tumor and just left debris at the site. Other patients represent much more of a challenge. They don't respond in just a few weeks. Like this patient, who I also treated over 6 years ago, came to me with liver and kidney metastases, and after 4 doses of Ipilimumab, had a CAT scan that looked like that week 12 image. You don't have to be a radiologist to think that that patient looks worse. But as I walked into the room with my medical oncologist speech of, "I'm sorry, sir, we have to find a different treatment," this very New York kind of patient stopped me at the doorway and said, "I don't want to know what the pictures show. I have to tell you, I feel better." And so I did what any self-respecting oncologist would do, turn right around and make sure I looked at the right films. And after I convinced myself that I had the right films, I said, "Tell me more about how you feel better." And he said, "Well, just in the last week, my night sweats have gone away, my fevers have gone away, and my liver doesn't hurt anymore when I go to sleep at night." And so I sat back and I said, well, maybe it's just going to take a little longer. Maybe Dr. Leach, and his mice were correct that tumors can grow before they regress. And perhaps what we should do is make the very unorthodox suggestion to this gentleman with radiographically progressive cancer that he go home and do nothing. And he agreed to do that. And he came back 8 weeks later without any further treatment, and most of that disease had regressed. And it has stayed regressed now for over 6.5 years. And so we learn a lot about biology from studying individual patients. And we learned a lot about drug development from studying patients like this. In fact, our observations of single patients, not just myself, but my colleagues around the world, changed the endpoints of clinical trials from radiographic response-based endpoints to overall survival. Because if you draw a line at, say, 12 weeks and say, we're going to judge the efficacy of this medicine by how many people have tumors that get smaller by this empiric period of time, you're going to lose out on the biologic activity of a medicine like this. But if you go for the gold standard endpoint, which is how long do people live, it takes longer, and nobody wants to wait longer for answers, but it takes longer, but it captures the biology of this treatment. And so we and others came up with various categories of what kinds of responses can be seen with immunotherapy. 2 of them are conventional, 2 of them are very strange. And we started to look at all the patients that we treated and think about ways to change endpoints for immunotherapy trials as a way to try to speed drug development. And we learned some lessons, that checkpoint blockade works, durable disease control can be observed, There are unique mechanisms of toxicity that make it very different from chemotherapy or other forms of anti-cancer therapy. The side effects of this are mechanism-based. Patients get inflammation in the skin and the GI tract, and we need to be prepared to manage those, and now we are. But this heterogeneous response kinetics really was the most important step forward. We recognize that we need different ways to think about results if we want to have successful drug development. And so we came up with these different response criteria called the immune-related response criteria. And what we said is basically take the usual rules that you have, measuring things on CAT scans at about week 12, and just make two changes. Require patients who have asymptomatic progression to get a confirmatory scan to make sure they're not actually getting better when you think they're getting worse. So just do what we did with that liver metastasis patient. And second, stop separating index lesions from new lesions. Just because a patient has one new tumor doesn't mean that they have progressive disease. If they've got 99 lung metastases that went away, but one new tumor under the skin, that one new tumor under the skin, which you now can see on a scan, may in fact be a tumor that was there before. You just can see it better because it's full of lymphocytes, and perhaps in about 6 weeks it will regress too. So with that in mind, we recategorized patients in the entire phase 2 program for Ipilimumab. And what we showed is that if patients respond on schedule at week 12 by standard imaging criteria, that's that top blue line, obviously they do quite well. If they progress by any response criteria, the red line, they do quite poorly. But if you look at that dark blue line very close to the top, those are patients who actually were scored as progressors by standard criteria, but because of the delayed response and also the new lesion index lesion disparity, we actually moved them into the category of responder, and you can see that their overall survival is statistically the same. And so these criteria now are being prospectively validated in different clinical trials because we think that it's not just unique to Ipilimumab. This is something that could be applicable to anti-PD-1 or other biologic therapies. Now, the pivotal data which really got this drug on the map was a phase 3 randomized trial done in almost 700 patients with refractory metastatic melanoma, a difficult disease for which there had been no approved drugs for 13 years before this. It was a very well-designed study of a cancer vaccine, Ipilimumab, or the combination. And the results were quite clear. The two groups, the green and the blue lines, were the Ipilimumab-containing groups, had a statistically significant improvement in overall survival. The risk of death was reduced by about 32% for these groups compared to the group that got vaccine alone. And this data led to the approval of Ipilimumab in March 2011 for the treatment of advanced metastatic melanoma. Now, the number of people who benefit from this medicine is probably between 20 and 30%, and it is accompanied by side effects. So we definitely have more work to do. But what this did is it opened the door to other immunotherapies and proved that durable disease control is a reality with immunotherapy because you can see the tail on those survival curves. Very few patients will progress and die after they initially respond. However, in our quest to build better combinations, we again look at anecdotes, patients who we have treated in different trials or even with now commercially available medicine, such as this 33-year-old woman whose medical history with metastatic melanoma is recounted on this slide. She developed an unresectable recurrence in the subpleural space in August of 2009, went on Ipilimumab, and in panel A in the upper left, the arrow is pointing to this subpleural metastasis. She developed slowly progressive disease. So remember that the median survival of patients with metastatic melanoma is about 9 months in this era. And so August 2009 to November 2010, she's not that much worse because she hasn't developed widespread metastases, but she's not any better. And this subpleural metastasis is painful. She's developed some small nodules in the spleen, and we felt the necessity to do something different. And so we asked that radiation be delivered to this tumor in the subpleural space. And the map for that radiation treatment plan is on the bottom in panel F. And after that radiation in January 2011, no big change. But 3 months later, in April 2011, most of the disease regresses, both the disease in the radiation field as well as the disease in the spleen and the lymph nodes outside the radiation field. And this, especially the radiation oncology literature, is consistent with something called the abscopal effect, treating a solitary tumor in a very meaningful way to get it to regress in the context of a properly tuned immune system could lead to essentially a systemic immune response capable of regressing these distant tumors. And we believe that's what happened to this woman. In fact, we looked at a comparison between what her immune system was seeing just before and after the radiation, forgetting about what the Ipilimumab did, using a technique we term seromics, which is a multiplex way to look at antibodies to different targets. And we showed that right after the radiation, she had 10 new antigenic targets recognized, 2 of which were immediately interesting to us, showing that indeed the radiation, in the backdrop of the Ipilimumab as well, was able to turn that tumor into essentially an autologous vaccine site. And this has now led the way to the development of multiple clinical trials using Ipilimumab with radiation to try to broaden the efficacy in melanoma as well as in other diseases. And in prostate cancer, there has been for quite some time a trial of radiation with Ipilimumab for patients with bone metastases. But again, I think it's important to recognize that this is not one-trick pony. This is one medicine that has opened the door to many. And I'd like to talk about the group of drugs on the bottom right-hand side, which are all medicines that interfere with a pathway called the PD-1 pathway. And PD-1 stands for Program Death 1, a particularly bad acronym for an anti-cancer drug. But this is an important pathway that normally controls the activation of T cells. The PD-1 molecule is upregulated on exhausted T cells, and in some cases can actually lead to the death of T cells when it meets its ligand, called PD-1 ligand or 1 or PD-1 ligand 2. Now, conveniently, many cancers have learned to upregulate this ligand on their surface as a way to evade the immune response. And so we believe that this is an important pathway in trying to induce tumor immunity. And in fact, there was recently several publications in the New England Journal of Medicine and many presentations at ASCO about the PD-1 blocking antibodies. And so these are what are called spider plots. This is a very informative way to look at the activity of medicines like this, where each line represents an individual patient and the growth curve, essentially, for their burden of disease radiographically. So patients who have lines going up represent those whose tumors are getting larger, and those lines going down are those who are responding. This is one cohort from the Bristol-Myers Squibb anti-PD-1 trial that was presented by Steve Hody at ASCO this year, and also highlighted by Suzanne Topalian. And you can see that there are a significant number of patients with advanced melanoma whose tumors durably regressed with the use of an anti-PD-1 antibody, again validating Dr. Allison's theories about checkpoint blockade. And again, it's the depth of these responses, how far down those spider plots go, and how long they stay down, because it's very apparent that once they're down, they seem to stay down. Now, the real surprise in this field came from spider plots like this, which represent patients with advanced non-small cell lung cancer that was refractory to chemotherapy or targeted therapy. Immunotherapy was always considered an intervention that benefited most some niche diseases like melanoma and renal cell carcinoma. But for very prevalent cancers, difficult, aggressive cancers like non-small cell lung cancer were never really thought about as reasonable targets for immunotherapy. However, I think we, sort of the believers, always imagined that immunotherapy treats the patient and not the tumor. And it may not matter so much what exactly the tumor is, because if you can get the immune system to see the tumor, that is really the goal. And so it was not then surprising to some of us that patients with non-small cell lung cancer could have these durable, deep regressions after PD-1 blockade. And this has really, I think, blown the doors off the idea of using immunotherapy to treat a lot of different malignancies. It has led to a proliferation of medicines that all target PD-1 and PD-1 ligand, and as well as multiple different combination therapies. And this is really what we needed. We needed proof of principle in more than one disease that treating the patient needs to be considered as seriously as treating the tumor. Now, building on that again, scientists from Jim Allison's lab, as well as some colleagues from BMS, have been looking at combining Ipilimumab with anti-PD-1, because these are separate pathways. And so there could be benefit from adding them together. And so this is some preclinical data showing that mice treated with an experimental vaccine and either PD-1 or CTLA-4 blocking antibodies or both, and the outcomes are better when you use all of that together. And in response to that, as well as some other data, myself and Mario Schnoll from Yale have been leading a clinical trial in patients with advanced melanoma of Ipilimumab with MDX1106, which is the PD-1 blocking antibody. And we are making our way through this dose escalation, data to come in a few months. But the very important thing is that we have not found such significant toxicity that we had to shut the trial down. These are separate pathways. And evidence that combining them could be very, very powerful comes from the idea that these are not identical. They don't seem to converge, because we've now noted that some patients who were previously progressing on Ipilimumab, when given anti-PD-1, will respond, and vice versa. Some patients who were on some of these PD-1 trials and didn't have a response, and then given Ipilimumab as a standard of care, will then respond. So it seems that these are complementary rather than overlapping pathways, which provides additional rationale for studies like this. I think the future is very bright for combination therapies. We recognize, even as very focused immunologists, that there is a world outside of immunology, that we are dependent upon the development of therapies that also target the tumor to bring the antigen to the attention of the immune system. And so combining Ipilimumab with radiation therapy, with targeted pathway inhibitors, with chemotherapies, very, very important. As well, combining Ipilimumab with PD-1, as well as the next generation of checkpoint blocking antibodies, as well as agonist antibodies, ones that don't have very pronounceable names yet, anti-GITR, anti-LAG3, anti-OX40. These are all in the early days of either clinical trials or about to be launched clinical trials. And so we really see that once we had a proof of principle, after literally over 100 years of thought about immunotherapy, we now are running toward the goal of having more patients benefit from this type of durable disease control. Thank you very much for your attention and for the opportunity to speak to you today.